Lecture 4 in the Practice of Cardiac Sonography 4 unit is entitled Advanced Techniques for Evaluating Valve Disease. The contents of the lecture are 1. Identifying the mechanism, 2. Evaluation with echocardiography, 3. Specific measurements, and 4. Communicating findings. Following this lecture, you'll be able to firstly describe the common underlying causes of valvular disease. Second, define how to evaluate valvular disease with echocardiography. Thirdly, execute measurements to quantify valvular stenosis and regurgitation. And fourthly, communicate findings related to valve disease in a professional manner. Chapters 11 and 12 of Catherine Otto's text are the recommended reading for this lecture, together with the most recent recommendations from the American and European associations related to valve regurgitation and aortic stenosis, and both of these documents are available via Views. Identifying the mechanism. Normally, blood flow within the heart and throughout the circulation is forward moving, that is, antegrade. As you know, the synchronous rhythmic contraction and relaxation of cardiac myocytes results in changes in pressure within the heart. Increasing pressure forces valves to close and others to open, so that blood flows forwards. And normally, valves open fully to allow the blood to flow through them, and close tightly afterwards to stop blood flowing back. Incomplete valve opening, which results in obstruction to blood flow, is termed stenosis. In adults, calcification is the most common cause of valvular stenosis, followed by post-inflammation changes, for example after a streptococcus infection that results in rheumatic fever and rheumatic heart disease. Congenital abnormalities to the valve may also cause stenosis. Incomplete valve closure, which results in reverse blood flow, is termed regurgitation. Generally speaking, valve regurgitation is termed as either primary or secondary. That is, it is termed primary when it is due to valve leaflets themselves, or it is secondary because of heart chamber remodeling. As you know, calcification affecting the leaflets and valve annulus, leading to thickening and reduced mobility, is the most common cause of aortic stenosis in adults. Rheumatic fever and its ensuing pathological thickening of the mitral leaflets is the most common cause of mitral stenosis in adults. Aortic stenosis occurs rarely in an acute setting. More often, aortic stenosis is chronic. That is, it occurs as a result of pathological changes that develop over time. Aortic stenosis results in increased LV pressure, and as a result, left ventricular hypertrophy is a typical response to chronic aortic stenosis. Acute mitral stenosis is also rare. More often, mitral stenosis is chronic. Chronic mitral stenosis results in increased left atrial pressure. As a result, left atrial dilatation is a typical response to chronic mitral stenosis. These 2D images show characteristic changes due to chronic aortic stenosis, increased leaflet and annular thickening and brightness, reduced leaflet mobility, and left ventricular hypertrophy. And the 2D images on the right show chronic changes due to chronic mitral stenosis, increased leaflet thickening and brightness, reduced leaflet mobility, and left atrial dilatation. As mentioned, incomplete closure of valve leaflets that results in reverse blood flow is termed regurgitation. Mitral valve regurgitation occurs when two mitral leaflets don't coapt properly, that is, don't close properly. Primary mitral regurgitation occurs due to a structural alteration or alterations to the mitral valve apparatus. An example of this is an alteration to one or both mitral leaflets that cause prolapse and blood regurgitation. Secondary mitral regurgitation is regurgitation through a structurally normal mitral valve due to left ventricular or left atrial remodeling that prevents the leaflets from closing completely. Example of this type of mitral regurgitation is MR due to dilated cardiomyopathy. Tricuspid regurgitation occurs for similar reasons. Primary tricuspid regurgitation occurs due to a structural alteration or alterations to the tricuspid valve apparatus. An example of this being the anatomical alterations that occur with Ebstein anomaly. Secondary tricuspid regurgitation, which is far more common and responsible for about 80% of significant tricuspid regurgitation, is regurgitation through a structurally normal tricuspid valve due to right ventricular or right atrial remodeling that prevents the leaflets from closing completely. Primary aortic regurgitation occurs due to a structural alteration or alterations to the aortic valve cusps. An example of this being the anatomical alterations that occur with a bicuspid aortic valve. Alteration in the size and shape of the aortic root, an ascending aorta that may, for example, occur with Marfan syndrome, cause secondary aortic regurgitation. Blood is incompressible, so the regurgitant volume must be contained in the chamber affected. Therefore, the degree of chamber dilatation, together with patient history, provide indications about the degree of regurgitation. This is particularly the case for mitral and tricuspid regurgitation. Recent severe trauma or a dissection can result in significant valvular regurgitation, which a patient is unlikely to tolerate for any great length of time. While the effective regurgitant orifice for both severe acute and severe chronic regurgitation will be large, there may well be very minimal chamber dilatation with acute severe regurgitation, which is in contrast to chronic significant regurgitation. Evaluating valve disease with echo. As the name suggests, the Western Sydney University Comprehensive Imaging Sequence indicates images and measurements that should be used to conduct a comprehensive study. It's not an exhaustive list of all images and measurements that can be acquired and measured. It's meant to provide a framework to ensure that an exam is comprehensive and methodical. The imaging sequence includes most of the imaging modalities. That is, it includes 2D images and measurements, colour, pulsed wave, continuous wave, and tissue Doppler images and measurements. All these modalities can be used when evaluating the heart valves. Moreover, multiple modalities from each of the standard imaging windows should be used, so that the evaluation is made using a combination of images and measurements from multiple views. As 2D imaging enables real-time images and measurements of cardiac anatomy and function, 2D is essential for assessing valvular anatomy and function. Moreover, it can be used to guide M mode, so as to place the cursor where it should be placed. M mode should be used for evaluating the valves, for example, to assess mitral leaflet motion, which can be very clearly displayed with M mode. With 2D, the number of aortic valve cusps can almost always be determined with 2D. And using multiple 2D images, all three tricuspid valve leaflets can be examined. As colour allows patterns of intracardiac blood flow to be seen, colour Doppler is an essential mode when evaluating heart valves. However, like the other Doppler modes, colour does have limitations, and there are two of particular importance when imaging heart valves: gain and signal aliasing. When optimizing gain settings, it's important to aim for a setting that is high, but not so high that random speckles are seen. That is, colour speckles in regions where colour shouldn't be seen. The two images at the bottom of this screen are the same with one exception: the gain settings. In the image on the left, the gain is too high. Random speckles can be seen at the edges of the colour box, and the regurgitant jet looks large. In the image on the right, the gain settings are too low. No random speckles are seen, but the regurgitant jet is hardly discernible. The Nyquist limit should be set most often around 60 to 7 centimeters per second at the limits. While flow may often exceed this limit, it's recommended that this is the setting that is used as a standard. It's also important to be aware of other factors that influence the colour Doppler appearance. Here we'll consider two non-technical factors that influence the appearance of regurgitant jets. Factors that lead to a larger jet, apart from gains too high and Nyquist limits too low, are high velocity jets or valves with multiple regurgitant orifices. That is, these are often overestimated. Factors that lead to a smaller jet area, apart from gains that are too low and Nyquist limits too high, are low velocity jets and eccentric jets. That is, these are often underestimated. For example, the image on the right shows a narrow eccentric jet of mitral regurgitation, which is in fact severe. Flow convergence with colour Doppler. Locating flow convergence proximal to a regurgitant orifice gives information about the magnitude of valve regurgitation. A well-defined small flow convergence, less than 3 millimeters, combined with a small jet is specific for mild mitral and tricuspid regurgitation, whereas a large flow convergence greater than 1 centimeter, recorded at a minimum 50 to 70 centimeters per second as the Nyquist limit, that persists throughout the duration of flow is specific for severe mitral and tricuspid regurgitation. Pulse Doppler. Aspects of forward and reverse flow measured with pulse wave Doppler give information about the magnitude of regurgitation. Two ways to use PW to evaluate mitral regurgitation. First, by measuring mitral inflow. If MR appears severe, an E-wave velocity greater than 1.2 meters per second is supportive of a severe grade. In contrast, A-wave dominant flow excludes severe mitral regurgitation. Secondly, measuring pulmonary vein flow. Systolic flow reversal in more than one pulmonary vein is a specific sign for severe mitral regurgitation, while normal pulmonary vein flow indicates that MR is not severe. Aspects of forward and reverse flow measured with PW also give information about the magnitude of tricuspid regurgitation. Normally, hepatic vein flow measured with pulse wave Doppler from the subcostal window is systolic dominant, with the systolic waveform shown below the baseline. In cases of severe tricuspid regurgitation, there is systolic flow reversal in the hepatic vein, shown by flow in systole above the baseline. Continuous wave Doppler. The density and shape of the CW regurgitant signal help to determine the magnitude of mitral regurgitation. Firstly, the spectral density. With severe mitral regurgitation, the regurgitant signal is dense, almost or as equally dense as the forward flow signal. Secondly, the regurgitant signal profile. With severe mitral regurgitation, the signal is triangular in shape. A more parabolic profile indicates that the mitral regurgitation is not severe. And continuous wave Doppler density and shape also help to determine the magnitude of tricuspid regurgitation. Firstly, the spectral density. With severe tricuspid regurgitation, the density is almost as dense or as dense as the forward flow signal. And secondly, the regurgitant signal profile. With severe tricuspid regurgitation, the signal is triangular in shape. Specific measurements. This part of the lecture will focus on specific measurements for three common valvular diseases: aortic stenosis, mitral regurgitation, and tricuspid regurgitation. The most recent American and European guidelines will be used to indicate how best to evaluate these pathologies. Firstly, aortic stenosis. In 2017, the recommendations indicate that three measurements should be used for all patients with aortic valve stenosis. The measurements are, firstly, the peak aortic velocity in meters per second with CW Doppler. Secondly, the mean valve gradient in millimeters of mercury with CW Doppler. And thirdly, an aortic valve area in centimeters per second using the continuity equation with the necessary 2D, PW and continuous wave Doppler measurements. Regarding the first two measurements, the maximum velocity and mean gradient, the recommendation document indicates the following. These measurements need to be made from multiple views. The highest value should be used when making calculations, and a PEDOF probe should be used in search of the highest value. The third measurement, aortic valve area. The aortic valve area, using the continuity equation, is based on the assumption that there is conservation of matter. That is, an equal volume of flow through the heart chambers and across the valves, and in this case, that the LVOT stroke volume is equal to the aortic valve stroke volume. To ensure the most accurate aortic valve measurement, the recommendations indicate that the LVOT diameter should be measured 5 to 10 millimeters apical of the aortic valve, that the stroke volume sample site, that is, the LVOT PW VTI sample site, is 5 to 10 millimeters apical of the aortic valve in order to match the site of diameter measurement, and that care be taken when measuring gradients using CW Doppler to ensure that an optimal parallel angle is used. Ranges that are indicative of the severity of disease are given for each of the measurements. Again, the recommendations indicate that a severity grade be based on a combination of measurements. Quantifying mitral regurgitation. Estimated regurgitant orifice area is the primary measure of regurgitant lesion severity. To estimate the orifice area of a regurgitant mitral valve, the 2017 recommendations suggest the use of the flow convergence PISA method. PISA stands for Proximal Isovelocity Surface Area. Calculation of the regurgitant orifice using this method is based on the continuity equation, although the equation is rearranged as per the text on the right of this slide to account for the methods used to make the measurement. Fortunately, the complicated maths is undertaken by the machine, and the method is relatively straightforward provided that the sonographer acquires the appropriate measurements correctly. The PISA method for measuring the regurgitant orifice area combines continuous wave Doppler and color Doppler. Ultimately, there are three important steps needed to make this measurement of mitral regurgitation. Firstly, sample the mitral regurgitant jet with CW Doppler and trace the MR signal at a high sweep speed, making note of the time in the cardiac cycle that the signal is at its peak. Secondly, view the mitral regurgitant jet with color Doppler. Adjust the color aliasing velocity baseline down to between 30 and 40 centimeters per second and acquire an image. And thirdly, with the acquired color image with the baseline adjusted, measure the PISA radius at the time of the peak regurgitant velocity noted with the CW signal. Measure the PISA radius from the aliasing point, the color signal, to the vena contracta. To ensure that your measurement is as accurate as possible, take care to optimize the continuous wave Doppler angle. Moreover, eccentric jets may be very difficult to measure, and another method may be needed in that case. Calipers should be placed carefully when measuring the PISA radius, and the radius should be measured at the time of the maximal regurgitant velocity. Usually, a mitral regurgitant ROA measurement by PISA less than 0.2 centimeters per second equates to mild regurgitation. If it's between 0.2 and 0.39 centimeters squared, it's moderate. And if it's equal to or greater than 0.4 centimeters squared, it's severe mitral regurgitation. Another method for measuring tricuspid regurgitation. The 2017 recommendations indicate that, together with studying the continuous wave signal density and profile and hepatic vein flow when evaluating tricuspid regurgitation, that measuring the vena contracta is helpful for evaluating tricuspid regurgitation. As you know, the vena contracta is the narrowest portion of the jet immediately below the valve. That is, it's a cross-sectional measurement of the blood column as it leaves the regurgitant orifice. For optimal evaluation of tricuspid regurgitation by vena contracta, the Nyquist limit should be around 70 centimeters per second. A zoomed, RV-focused apical four-chamber view and a narrow colour box should be used. If the vena contracta is less than 3 millimeters, it's indicative of mild tricuspid regurgitation, whereas if the vena contracta is greater than 7 millimeters, it's an indication that the tricuspid regurgitation may well be severe. Communicating findings. It's recommended that precise language be used when communicating findings about valvular disease. Chamber size and function should be clearly indicated with the support of quantitative measures. Terms such as normal or mildly reduced or severely reduced should be used. Terms such as good or not good should be avoided. Notes about the structure of the valve should be made, including any calcification or thickening, along with the valve's motion, particularly if its motion is abnormal. Comments about the nature of the regurgitant lesion should indicate the general direction of a regurgitant jet, and it should include measures that help to grade the degree of regurgitation. Ultimately, quantitative measurements are best, particularly when performed correctly. In conclusion, identifying the cause of valvular dysfunction is important. Generally speaking, valve disease is the result of a primary or secondary condition. Secondly, evaluation of valvular dysfunction requires a comprehensive and methodical approach to an echocardiographic study and the use of different methods and measurements. Knowledge of the methods for quantifying valvular disease is important. Quantification is the best way to evaluate valvular disease, of course, especially when it's performed correctly. And precise language is needed to communicate findings about valve disease.